This video is sponsored by Bootcamp.com. Check it out for INBDE prep and use coupon code MENTALDENTAL for 10% off. Hey everyone, Ryan here, and welcome back to our oral medicine series. This video will be all about obstructive sleep apnea. Obstructive sleep apnea falls under the greater category of sleep disorders, and so you get an idea of how prevalent they are. 70 million Americans suffer from a sleep disorder, and 18 million Americans have OSA or obstructive sleep apnea specifically. Now, sleep disorders generally are more common in females, but obstructive sleep apnea specifically is more common in males. Many people think of sleep as this passive, thoughtless process. Technically, it's anything but that. Sleep is an active process which follows its own program with a sequence of different sleep stages and nervous system functions. Interestingly, sleep represents 1/3 of the human life. We spend 1/3 of our lives sleeping, so we ought to know a little bit about how it works. So sleep happens in two different phases. We have non-rapid eye movement sleep and rapid eye movement sleep. So this NREM sleep is dreamless. It involves a quiet brain in a resting body, and it makes up about 80% of your total sleep time. When you're in this non-REM sleep, you start with stage 1, which is kind of like dozing off. And when you get to stage 2, that's when you experience a drop in body temperature, your muscles begin to relax, your breathing slows down, your heart rate slows down, and brain activity as a whole slows down. Then when you get to stages 3 and 4, you experience what's called slow wave sleep or deep sleep. You have decreased muscle tone, delta wave brain activity. This is where you're really getting your restorative sleep. And then we go backward to stage 3, stage 2, and sometimes stage 1 again. And then we get to this REM or REM sleep. And this is where you start to dream. And you have an active brain in a paralyzed body. And this makes up about 20% of your total sleep time. During this REM sleep, you have skeletal muscle hypotonia. So when I say a paralyzed body, your body physically does not move during this REM sleep. And the average human has 5 sleep cycles per night at 90 minutes each. So if you do the math, that's 7.5 hours. So that was the sleep cycle. Now, what can go wrong with it? We have insomnia, which is difficulty falling and or staying asleep. We have parasomnia, which refers to sleepwalking and night terrors. We have sleep-related breathing disorders. This includes snoring, central sleep apnea, and obstructive sleep apnea. And we'll talk more about each of these in just a bit. We have sleep-related movement disorders. These include things like restless leg syndrome or nocturnal bruxism, grinding of the teeth. Narcolepsy is overwhelming daytime drowsiness where you just fall asleep suddenly during the day. And then we have circadian rhythm sleep-wake disorders. This includes things like jet lag if you're traveling across long distances, across different time zones, and shift work disorder. So if you work the night shift or rotating shifts for your job, you can experience a misalignment between the body and the circadian rhythms that regulate your sleep-wake cycle. So that's a nice overview of all the kinds of sleep disorders. Again, we're going to hone in on the breathing disorders, snoring, central sleep apnea, and obstructive sleep apnea. So first up is snoring. About 40% of adults snore to some capacity, more males than females, so that's actually quite a bit. Snoring results from the vibration of loose, soft tissues, so the soft palate, uvula, and the posterior tonsillar pillars as air passes over them during inspiration or breathing in. Snoring in children is usually due to enlarged tonsils or adenoids. Important to know, snoring alone does not necessarily mean a patient has apnea. More on that later. And then we have the different forms of sleep apnea. So central sleep apnea is where airflow stops as a result of a temporary lack of inspiration, which can occur with poliomyelitis, spinal cord injury, or encephalitis. So it's a central nervous system issue. The nervous system is not functioning properly. And then we have obstructive sleep apnea, where there's an interruption of breathing during sleep due to a nasopharyngeal, oropharyngeal, or hypopharyngeal obstruction. So it's a physical blockage issue. This could be things like swollen adenoids and tonsils, an anatomically small airway, a malocclusion could potentially contribute to this, or even sinus problems and allergies. And then we also have mixed or complex sleep apnea, not listed here. That's basically a combination of both of these, usually with central apnea occurring first, followed by bouts of obstructive apnea. So let's clear up some definitions here regarding apneic episodes. So an apnea, the term itself refers to a total cessation of airflow for at least 10 seconds. So this is an absolute pause in breathing, a complete obstruction of the airway. So that would be shown here. This is an apnea episode. Hypopnea is a reduced airflow for at least 10 seconds. So a period of shallow breathing, maybe gasping. So the airway is still pretty obstructed in this case. So this would be an example of a hypopnea. And then we have one tier lower would be a respiratory effort-related arousal. And this is an increased respiratory effort for at least 10 seconds, but it still leads to an arousal. And we'll talk about what that means in just a little bit. So maybe that would look something like this. And then no obstruction at all, we have normal breathing. So what does it all mean? Well, the AHI, or Apnea-Hypopnea Index, is something used to quantitatively measure the severity of someone's sleep apnea. It's measured by taking the number of episodes of complete blockage for 10 seconds, and you add that to the number of episodes of partial blockage for 10 seconds, and then you divide by the total hours of sleep. So for example, a guy has, let's say, 20 apneas and 20 hypopneas, and he sleeps for 5 hours during the night. That would be 40 divided by 5, which would be an AHI of 8. So if that person were an adult, that would put them in the mild category. If they were a child, it would put them in the moderate category. So for adults, mild is 5 to 15 episodes per hour, moderate is 15 to 30 episodes per hour, severe is 30 or more episodes per hour. And then for children, the index is a bit more stringent. So 1 to 5 is mild, 5 to 10 is moderate, and then 10 or more is severe. So why do these patients wake up so many times throughout the night? Well, a partial or complete breathing obstruction will lead to hypoxia and hypercarbia. That means a shortage of oxygen and an excess of carbon dioxide, which leads to arousal or waking up from sleep. And frequent arousals cause fragmented sleep of poor quality. And that'll be important when we consider the signs and symptoms of this disease. Spoiler alert, it's much more than just loud snoring that can bother your partner. And obstructive events in children occur primarily during which sleep cycle? That would be REM sleep. So if you got a question that asked about that, the REM sleep is where you're going to see the bulk of these episodes and arousals, particularly in children. So what are some signs and symptoms? We expect intermittent snoring with gasping, choking, and complete absence of breathing in the case of those apneic episodes, somnolence, which is excessive daytime sleepiness, fragmented light sleep, nocturnal sweating or night sweats, nocturia, which means frequent urination during the night, poor memory, morning headaches, and then these next two should sound familiar because they were part of the sleep acid triad I talked about when we were talking about tooth erosion in the last video. So GERD, or gastroesophageal reflux disease, is due to an increased intrathoracic pressure caused from obstructive sleep apnea, and nocturnal bruxism refers to tooth grinding or clenching during sleep. So this might be coupled with tooth wear, grinding sounds, and or jaw discomfort. And then most importantly, we have cardiovascular symptoms, and these include things like hypertension, arrhythmia, and stroke. So obstructive sleep apnea really taxes the heart, and it can lead to serious complications, even death in some severe cases. So those are some of the signs and symptoms ranging from snoring all the way up to stroke. So there's a long list of risk factors here. So we'll go through them pretty quickly. We have obesity because obstruction may be due to fat accumulation on the pharyngeal wall, as well as fat deposition at the base of the tongue, which can put pressure on the airway. Older age is a risk factor, but children can have it as well. Males are more likely to have OSA than females. We talked about that earlier on. A family history of OSA, alcohol or sedative use, especially around bedtime, a supine sleeping position, so laying on your back is worse for OSA, and that's why they often recommend rolling to your side to help stop snoring. Smoking is a risk factor, breathing disorders such as asthma or COPD, menopause due to the change in sex hormone levels. And then next we have anatomic abnormalities. I'm going to sit on this one a little bit because there are a lot of details that I think are important to know. So a high and narrow palate. This would cause a higher nasal resistance and just overall decreased space for the tongue to live. This would again kick the tongue back a little bit further, putting some pressure on the airway. Narrow dental arches goes along with that. An increased anterior face height and overjet. This often accompanies lip incompetence, which is a signal of someone who's mouth breathing, may have some nasal obstructions. Retrognathia, so retrusive jaws, especially of the mandible, will put additional constraint on the airway. So what are some examples that we would see mandibular hypoplasia besides those class 2 and bimaxillary retrusive patients? Well, we could see it in Pierre Robin sequence, Treacher Collins, and craniofacial microsomia, for instance. An elongated soft palate, a large tongue or macroglossia. Where could we see this? This could come in play with Beckwith-Weidman syndrome, amyloidosis, acromegaly, multiple endocrine neoplasia type 2, and hypothyroid. Enlarged uvula, and finally tonsillar hypertrophy, especially in children. I could also include hypertrophy of the adenoids as well. And then for some more specific things, sickle cell anemia actually is a risk factor due to sickle cell disease related adenotonsillar hypertrophy. So that goes back to the one above. Mucopolysaccharidosis. This can actually manifest as macroglossia, a shallow oropharynx, once again adenotonsillar hypertrophy, and narrowing of the trachea and bronchi due to excessive accumulation of glucosaminoglycans or GAGs in the upper airway. And I remember this one because I think of someone gagging on these GAGs that are clogging up the airway. Just a quick memory tip to help you out with that one. And then patients with Down syndrome often have a small midface and cranium, a relatively narrow nasopharynx, macroglossia, hypotonia, and a tendency for obesity. And then for cleft palate patients, a palate repair, that repair surgery generally lengthens and or thickens the palate and increases the risk for developing sleep apnea. Since body weight is a significant risk factor for obstructive sleep apnea, I just want to talk briefly about BMI. Although it's by no means a perfect system, it is used around the world as a universal scale, and it's measured as body weight in kilograms divided by height in meters squared. The formula to the right here has been converted for weight in pounds and height in inches, so you just multiply by 703. And then these are the BMI categories. So sleep disordered breathing in general is underdiagnosed and undertreated, and 76% of physicians who are not sleep specialists do not screen for OSA, so there's a big hole there. And to be clear, dentists cannot officially diagnose obstructive sleep apnea, but we can screen for it and then refer to a physician or sleep specialist for an official diagnosis. How can we screen for it? Well, we can use the Mallampati Score, and this looks at the size of the tongue when not protruded and in a relaxed position. That's the original Mallampati Score, and then the newer modified version involves sticking the tongue out as far as possible, and then looking to see how much of the back of the throat you can actually visualize. And the idea behind this is a large tongue can block the posterior pharyngeal space, and it tells you about the likelihood of obstructive sleep apnea and potentially its severity. So it's scored from 1 to 4. The bigger the score, the bigger the tongue, or at least bigger relative to the rest of the mouth. So in class 1, again with the modified version with the tongue sticking out, you can see the soft palate, you can see the full uvula, and you can also see the tonsillar pillars. In class 2, you can see the soft palate, most of the uvula, and most of the pillars. In class 3, you can only see the soft palate and the very base of the uvula, and then in class 4, the only thing you can see is that hard palate. When the tongue presses up against the teeth constantly or regularly, you can see these wavy indentations in the side of the tongue. We call that scalloping. And scalloping of the tongue is actually 70% diagnostic for OSA. So that's a really quick way to just see how at risk a patient might be. The Brodsky score looks at the size of the tonsils instead of the tongue. It also correlates with risk and severity. So this one's scored from 0 to 4. The bigger the score, the bigger the tonsils. The Stop Bang questionnaire is a really good and easy questionnaire to ask your patients to assess their risk of having or developing obstructive sleep apnea. So Stop Bang is an acronym for 8 things that are risk factors, as most of these are things we've already talked about, as things that may predict someone having sleep apnea. And these items include snoring, being tired, having observed an actual apnea. So if their spouse or roommate saw that they had an apnea, you would check that one off as well. Pressure of blood, and what that means is someone who has hypertension, you would check that box. An elevated BMI, an age over the age of 50, a neck that has increased circumference, and someone who is of the male gender. And so again, the more of those that you check off, the higher risk you are. So for diagnosis of sleep apnea, a polysomnogram is the gold standard. You would go into a lab, you'd stay the night with all of these different wires hooked up to you, and get all these different measurements taken while you sleep. So these include an EEG, this measures your brain waves, an EMG, which measures leg and jaw muscle movements, an EOG, which isn't listed here, and that measures your eye movements. A thermistor would measure your oronasal airflow. Strain gauges would look at your chest and abdomen movement. A pulse oximeter would measure your blood oxygen saturation. And an ECG or EKG would look at your heart rate and rhythm. There's also a home self-test that can be prescribed for one-night use by your physician, and it's a watered-down polysomnogram without the EEG and some other components. But whatever route the patient decides to take, without a definitive diagnosis of OSA from a physician or sleep specialist, you as the dentist should not treat the patient for obstructive sleep apnea. So we need to have these results first before we can start implementing treatment, which we can talk about now. So what are some things that we can do to treat obstructive sleep apnea after they've been diagnosed? So we can start with the most conservative option, which is behavioral modification. So this can include things like weight loss, if weight is a contributing factor, encouraging the patient to use lateral decubitus sleeping position, so sleeping on their side, avoiding alcohol 2 to 3 hours before sleep, avoiding certain medications like benzodiazepines, barbiturates, narcotics, and muscle relaxants, encouraging just good sleep and good sleep hygiene in general. And then we could also think about nasal steroids. That would be only for mild obstructive sleep apnea. And then we have positive airway pressure. So the CPAP, which is continuous positive airway pressure, is the gold standard for treatment of OSA. It's effective for both moderate and severe obstructive sleep apnea, and it forms this pneumatic stent and pushes air into the nose in order to force the airway open. There's also a BiPAP, which is for more severe cases, and that delivers inhale pressure as well as exhale pressure. The success rate is actually excellent at about 95%, but the problem is compliance is very poor at below 50%. And that's because there are a lot of problems with the CPAP. It includes things like laceration of the bridge of the nose, and that's caused by the mask, rawness of the throat, as well as dry mouth, but you can use a humidifier to counter that one. Bloating of the stomach, nasal congestion, sleep deprivation, just because it's not very comfortable, and there are concerns about reduced cardiac output and renal function. So then we can move to oral appliances. Oral appliances are effective for mild to moderate obstructive sleep apnea, and how they work is they reposition and maintain the mandible and tongue anteriorly, increasing the upper airway volume and thus decreasing resistance to airflow. The success rate is pretty good, reported at around 76%, and compliance is also fairly good at about 65%. However, it can lead to occlusal changes with prolonged use, because it's basically a Class 2 functional appliance. Orthodontic treatment. So if a narrow maxilla is already an orthodontic issue for that patient, then you can think about expanding the maxillary arch. But this would mostly be for kids only. Rapid maxillary expansion treatment before the pubertal growth spurt produces greater transverse skeletal changes and has a greater effect on increasing nasal volume. So the earlier that you can intervene with orthodontic treatment, if a narrow maxilla is a problem, the better off you are. For surgery, there are a ton of different options depending on the level of the obstruction, whether it's at the nose, the mouth, or the throat. So we could do something like a septoplasty. This would reduce the nasal septum or inferior turbinates, a tonsillectomy and adenoidectomy for kids, a uvulopallido-pharyngoplasty, also referred to as a UP3, and that involves excision of excess soft palate tissue, the tonsils, uvula, and the posterior and lateral walls of the oropharynx. This also could include a lingual tonsillectomy at the base of the tongue, or a maxillary mandibular advancement osteotomy. So that would be an orthognathic surgery involving both a Le Fort advancement as well as a mandibular advancement, usually by a bilateral sagittal split osteotomy. So this would only be recommended really if the patient is bimaxillary retrusive, so their jaws are already retruded and they could benefit from having them brought forward. If it's done in a bimaxillary retrusive patient, you can see up to 96% success in those cases, so very, very high success. And lastly, we have this newer option called hypoglossal nerve stimulation. And what happens here is there's a little neurostimulator that's implanted, and it stimulates the tongue to push itself out rhythmically to help open the airway during sleep. So pretty interesting, and that's a newer treatment option. So that's all I have on obstructive sleep apnea. I hope you found this video helpful and that you enjoyed learning about this important disease process. That's it for this video. Thank you so much for watching. Please like this video if you enjoyed it and subscribe to this channel for much more on dentistry. If you'd like to support me, please check out my Patreon page. And thank you to all of my patrons for their support. You can unlock access to my video slides to take notes on and practice questions for the board exams, so go check that out. The link is in the description. Thanks again for watching, everyone. I'll see you in the next video.